All right, guys. Let's see how awkward I can make the respiratory system since I hate the sound of my own voice, and I'm sure these things aren't the most fun thing to watch. All right, respiratory system. I'm broken into upper and lower. Upper, we have the nostril. Maybe a little bit better pointer. Nasopharynx, oropharynx, laryngopharynx, and larynx. Then it comes down trachea, bronchi, bronchiole, and alveoli. I'm sure your instructors talked to you guys about the upside down tree analogy where we're branching it out, then allowing oxygen to come into our body. So the pleural lining is the outside lining of the lung. This allows the lung to move semi-independently of the ribs. It also gives it that protection because remember we want to make that negative airspace. It's going to talk about bronchioles and how they can constrict and dilate. This is going to come more when we get into med emergencies. We start talking about things like asthma. Real quick, anatomy of children and adults. Obviously, children aren't just shrunken down adults. Kids have smaller airways, their mouth, their nose, their tongue's proportionally bigger. Trachea is smaller. That cricoid ring isn't completely fused. It's not as hard, so there's more chance of it getting damaged. But because all those structures are bigger, the back of the head's bigger, we have to plan for that when we're dealing with our pediatric patients. We have to prop behind the shoulders on some. We have to allow for a little bit more jaw opening when we're trying to position the airway. So mechanics of respiration, diaphragm goes down, rib cage goes out, makes a negative airspace, allows for air to move in. I always think of it like those balloon stuffing things that you get for like Valentine's Day. They put the balloon in there, pulls a vacuum on it, allows a big open space so air rushes in, and you put your stuff in there. Now we're breathing out. That reverses all those muscles, relax, creates positive pressure inside the chest, moves air out. The biggest takeaway from this is remember that inhalation is actually the active phase. It's when we're using muscles to get the air in. Exhalation is passive. There's no muscle use. We just relax the muscles and allow air to go out. And the alveoli, can't even talk to. Remember we talked about where it's that real thin membrane, allows oxygen and CO2 to pass through. CO2 goes out, oxygen comes in. But I want you guys to pay attention to some of these numbers because these are going to kind of affect later on when we get to patient assessment in those situations. So if we have adequate tidal volume, we need respiratory rate. Adults, we're looking at 12 to 20 a minute. Elderly people, slightly higher. Children, higher. And then infants, they're so medically or metabolically amped up, they use a lot more oxygen. Perfusion, we're going to do a real quick breakdown on this. Perfusion is getting oxygen and glucose and other substances to and from the cell. We need to remember that because we want to think of it as that transport system around the body. So ambient air is about 79% nitrogen, 21% oxygen, and a handful of a few other things. We want to make sure that we can increase or lower that gradient in order to treat patients. So if we have a patient that has a good tidal volume, they're breathing in as much as we want them to, but they're still not getting oxygen across that space, we can increase the amount of oxygen. That way we're lowering this 79% nitrogen and we're upping the 21% oxygen. Therefore, we're raising the oxygen amount in their body. Airways can be obstructed. Things like bronchial constriction, bronchi damage, tracheal damage, even come down to things like food. We all know the choking obstructions. And all right, so mechanics of ventilation. We have tidal volume and we have frequency of ventilation, so respiratory rate. So in order to get enough oxygen in, we need tidal volume, which is the amount we breathe in, and then the frequency of ventilation. If you remember when we talked about cardiac output earlier in the little cardiac section or later, depending on how these videos are spliced together, they play off of each other. So If we need more oxygen around the body, more minute ventilation, we can increase the tidal volume, or we can increase the frequency of ventilation, or we can do both. Ideally, we want to do a little bit of both, but they can also compensate for each other. So if you're not able to take in a good tidal volume, we can increase the frequency of ventilation, and that's still going to give us that total volume out. And lo and behold, that's exactly what we just said. All right. Remember that the only place that we're actually getting oxygen across is at the alveoli. Everything else is just pretty much dead space. So all the bronchioles going up, trachea, nasopharynx, oropharynx, it's all dead space. The average amount is about 250 cc's or mLs, well, the total tidal volume is about 500 mLs. This is kind of giving you a little rundown of what can cause hypoxia. Remember that low tidal volume, slow ventilatory rate, fast ventilatory rate. Anytime we pressures inside the chest, we can cause our body to not be able to input enough air. There's quite a few things. The biggest thing to get from this is that we need to know our minute volume. We need to know how we can adjust that compared to how much we can adjust oxygen to allow perfusion to go for these patients. All right, guys, that was our little respiratory run through. Hope that helps. You guys take care.
Blood through the heart. So blood comes into the heart through the vena cava, goes into the right atrium, through the tricuspid valve. Everybody always knows the cheesy try before you buy thing. So tricuspid, then on the other side we're going to talk about the bicuspid valve. It's going to go into the right ventricle. The right ventricle is going to push it up through. It's going to go out the pulmonary arteries. Those are the only arteries in our body that's going to carry deoxygenated blood. After that, it's going to go to the lungs. Once it reaches the lungs, it will pick up oxygen. It will bring it back into the heart through the pulmonary vein, which I'm sure you've already guessed it. The pulmonary vein is the only vein that carries oxygenated blood. It's going to dump into the left atrium. It's going to go through the bicuspid valve. Like I said, try before you buy. Then it's going to go to the left ventricle. That's our powerhouse of the heart. That's where we're forcing all the blood out. And then it's going to go up, out the aorta, the ascending aorta, and down to the rest of the body. Now we're going to go over cardiac conduction. Remember we talked about with muscle cells, cardiac cells are the only ones that have the ability of automaticity. So they're the only ones that can fire themselves off. They don't need that external stimuli. But the heart works on a pacemaker system in order to keep the pump firing correctly. So we start out right up here with what's known as the SA node. It's always easier to go SA, same letters, just kind of start, so it helps me out a little bit. As that electricity fires down, it goes to what's called the AV node. After the AV node, excuse me, we start branching off into what's called the bundle of His. This is what's going to give electricity going around the whole ventricle. That way we're firing both ventricles all the way around and not just from the middle. Then we're going to go down. And this is your bundle branch. You have a left and a right. And then you're going to go off into your Purkinje fibers. Now remember, the heart has that automaticity, so it can create its own beats at times when it needs to. That's why we see some of the arrhythmias we see. But for you guys, this is the basic structure we want to know. We want to know that the SA node fires off, the AV node fires off, bundle of His, bundle branches. So cardiac output allows us to adjust what we're doing to meet the demands of the body. we have two options to adjust that. So if we need more blood, we need elevated cardiac output, we have two options. We can increase the stroke volume or increase the heart rate. Preferably, we like to balance the two out. Now, at the end of the day, if one of these starts to fail, the other one can increase. But remember, the body likes to live in that delicate balance, so anything that affects it is going to take more energy. The body hates to use more energy. So, say our stroke volume is depleted for some reason, you have death of some cardiac cells, body's in demand and it can't get the stroke volume up because the heart's been damaged in the past. So we can increase heart rate. So I like to use this little train analogy. So we have a train track going around. Ignore my car. And our train goes. We need to get stuff to our little supply place. Yeah, it's my little warehouse. We can increase the speed of the train, picking up things and dropping it off here, or we can increase the size of the cart. If we increase the speed, we're increasing heart rate. We're moving it around quicker, allowing it to pass our destination more times. If we increase the stroke volume, we're increasing the size of the cart, so we're able to carry more stuff. We don't necessarily need to go around any faster because we're bringing more stuff to our warehouse. Hope that helps make a little bit. Talk about veins versus arteries. So when we talk about the two, I want you to think of pressures. Think of the amount of force that's going through them. So arteries, we're going throughout the whole body. We're getting all that primary force from the heart. We need those big, thick walls. So if this is the inside of an artery, we have a big, thick wall with all muscle around here. That allows that artery to dilate and constrict. With veins, we got a thinner wall. If I can draw a thinner wall. I don't know. In veins, what they'll use primarily for moving is they'll have these valves. So it'll be like a little one-way valve that allows blood to come up, stops at this point, and works its way up. Oftentimes, people like to think of blood circulating in this one big motion. Think of it more like a little escalator system. So it moves up a little bit, stops, moves up a little bit, stops as the beat goes. Arteries allow us to vasodilate, provide more blood to certain areas. When we talk about the autonomic nervous system, it's going to allow that to perfuse those areas that we want it to. Hopefully that helps a little bit. Take care. What Frank Starling's law says is that the more you stretch a muscle, it's directly related to how much force it can contract back. So we're talking about the heart, we're wanting more force out. We increase what's called preload. What that does is it puts outward force on the heart and it causes that stretch. Think of a rubber band or those little elastic cords that people use in the gym. The more we stretch it out, directly correlates to how much force it can contract back in. Use my arrows. The reason this is important is we have to understand that the more we expand, the more preload we give, the more output we can provide. Hope that helps explain Frank Starling's law. Let's go over muscles real fast. So the three we need to know: smooth, cardiac, and skeletal. Smooth muscle, these are going to be controlled by the autonomic nervous system. These are the ones found in the GI tract. They're also found in vessel walls. Neural handwriting. These are the ones that do all those innate functions in the body that we don't have to consciously control. We don't have to sit there and go, please digest food. Cardiac muscle, like we talked about when I talked about cardiology, the biggest deal with them is they have what's called automasticity. I'm not going to write that because I'm going to spell it horribly wrong. If you need it, you know what Google is. I'm not going to. What they can do is allow that impulse to trigger from themselves. So if something gets blocked in the conduction pathway, they can stimulate and proceed to complete the pathway. Skeletal muscles, on the other hand, this is the big boss muscle. These are the ones that use that ratcheting system we talked about before. when they pull off of each other, that allows the muscle cells to contract real tight and give you that force.
All right, guys, it's going to be the circulatory system. We're going to be doing a quick overview of it. This is going to be in addition to what we already discussed earlier today. So, blood going to the heart, like we talked about before, from the body into the right atrium, through the tricuspid valve, right ventricle, to the lungs, back from the lungs into the left atrium, left ventricle. Coronary arteries, these are the arteries that the body uses to actually perfuse the heart itself, to give the heart the blood that it needs. So we have right coronary, anterior descending branch, you have a posterior descending branch also, and left coronary artery. This gives you a little bit better view of what we were talking about earlier. Arteries have that nice, thick, muscular wall. This allows them to constrict and dilate, to shunt blood different places. Veins, on the other hand, have that very thin wall. These primarily valves help move the blood up. And then what I forgot to discuss earlier was the capillary, which is that little teeny tiny structure. Very permeable membrane, allows nutrients and oxygen to move back and forth across the space. All right, circulatory system, blood component of red blood cells, white blood cells, platelets, and plasma. We know platelets help us clot. Plasma is more the liquid that the cells are floating in. Hydrostatic pressure is what we use to push all those things through that capillary membrane. So water's drawn out, plasma proteins can escape, it brings things with it. That's what all this is supposed to be. Just remember that pressure helps move things across that gradient. The circulatory system and tissue perfusion. We talked about this earlier when we were in the other room. The heart goes to the lungs. The lungs is where we pick up that O2, perfuse it out to the body, bring it to all those tissues. The cells use the O2, give off carbon dioxide. Carbon dioxide comes up into the heart, out to the lungs, diffuses across the alveoli, and then out of the body. All right. Now we're going to talk a little bit about some cellular metabolism. It's not too bad, so no panic attacks yet. All right. We have aerobic and anaerobic. Anybody from the 80s remembers that whole aerobic movement? I don't have a leotard or stocking socks, so we're out of luck. All right, so aerobic metabolism is basically in the presence of oxygen. If you can just remember aerobic, like aerobic workout, uses oxygen. Anaerobic is without. So anytime the cell wants to create anything, it uses different premises. So what we're talking about currently is ATP. It's the energy for the cell. It's what powers the sodium potassium pump. To create ATP, the cell needs oxygen and glucose. It's going to use that oxygen to help break down the glucose and turn it into ATP, which you can completely use the term ATP and energy interacting. They use ATP as their energy. This process happens in the mitochondria. With oxygen. Sorry, I don't mean to stumble. It's been a long day already. With oxygen, the body makes X amount of ATP, sends off things like carbon dioxide, heat, a little bit of water, and that ATP goes out and is used. That's what we talked about. This is our waste products. What we're using that ATP for is to power the sodium potassium pump. Remember that cells don't like moving things across the gradient because that takes energy. When it's a higher or lower quantity, they can move on themselves. But if we're moving against that gradient, we have to make sure that we have the energy to need. Somebody was just looking at me from the hallway window. It's gonna be one of those scary movies real soon. So ATP is required to power the pump. This helps move that sodium out. Potassium comes in.